40 years I've been in healthcare, and it's been fantastic. The impact has been about as great as the first healthcare revolution in the 19th century in terms of mortality and disability-free years of life. At the end of this period of time, every health service in the world faces these 5 problems: patient harm, unwanted variation, inequalities, failure to prevent disease, and waste. And if we look ahead, let's work on the assumption that there will be no more money. I, for one, wouldn't advocate putting more money into the NHS when one looks at the needs of, say, education or social care. The first thing in the variations is to maximise value by allocating optimally. I'm not interested in average or even the mean. Don't come telling me you're below mean in spending, you want more money, because, ladies and gentlemen, there is no more money. Of course, one of the weaknesses of programme budgeting knowledge is that it is by diagnosis, and we are also promoting programme budgeting by population group. Although lots of people have more than one disease, I've never yet met a patient who tells me they've got a long-term condition. You know, they tell me they've got asthma, they've got Parkinson's, and we spend £1 billion in asthma. £1 billion. And we still can't answer the question, is asthma care in Liverpool better than asthma care in Manchester? Other, you see, is a very common disease about which something must be done. Then the second variation, and this is the one I've been working on for many years. My wife, I wrote a little book on better value healthcare, and my wife said, oh, no one's interested in value. I said, no, but they will be. Just wait. Wait for the bankers to screw the economy. And quality improvement is very important, but doing the wrong things right isn't what we've got to do. We have to do the right things right to get high value. And when we look at variation in activity and costs, then we're moving into value business. And value is the relationship between outcomes and costs. And outcomes are good outcomes minus bad outcomes. So quality and safety are still very important. Yet there comes a point where spending more money in quality improvement doesn't give you value. There comes a time when spending more money in safety doesn't give you value. Oh, shock. You know, Dr. Gray said that, you know, there comes a point where you can spend too much in safety. Yes, there is. And there's very little that I can find in the health service that's, you know, it's absolutely clear it's ineffective. There is quite a lot of things taking place which don't have strong evidence of effectiveness. For example, in my discussions with the orthopaedic surgeons, I said, well, I agree hip replacement is usually a high value activity, but where did hip arthroscopy come from? As you do more interventions in a population, the benefits flatten off, but the harms go up in a straight line. So the same technology is a different offer to patients at different rates of intervention. Secondly, prioritising action, and we will be giving every clinical commissioning group information about where they lie, and often we don't know what's good and what's bad, and of course we're still quite weak on outcome data. Thirdly, systems and networks, and I'm starting to run workshops now where we ban the use of the words primary, secondary, acute, community, outpatient, and a few others if I can do it. These are 19th century words. 21st century words are system, network, pathway. We should know how many systems there are, and systems are delivered by networks. So in the 20th century, the pattern was professor, consultant, GP. In the 21st century, professor, consultant, pharmacist, GP, patient. Patient's as important as the professor. If the patient doesn't take the medicine the professor prescribed, who's more important in the value chain? The next thing we're promoting is population medicine. You need to look now at the people who are receiving the service. Are they the people who would gain most from the service? And we're now starting projects with this, a lot with elective surgery actually. Spinal surgery, for example, is a symptom of something going on with back pain in a population. These are systems problems, population-based systems problems. And it does mean that we want clinicians, or certainly a proportion of them, to split their brain and to think about both the individual patient when they're with the patient, but then for part of the brain to think about the fact that resources they're using are resources provided by the whole population, including patients who haven't been referred. You see, there are really only two ways of doing things: bureaucracies and markets. Bureaucracies, a good bureaucracy, employs people openly and fairly, promotes on merit, and prevents corruption. In my view, a bureaucracy cannot solve complex problems like how do you deal with the problems of frail elderly people who are also mentally ill, or these are too complex. Markets have a part to play. Which computer system shall we buy? These sorts of questions are market questions. But actually, the ants work in a different way. I've been visiting ants for the last 5 years, and they're what's called complex adaptive systems. See, the queen ant doesn't tell people what to do. They have jobs, but they change their job in the light of problems. And the third revolution is not my phrase, it's Manuel Castell's, and he said, he doesn't write about healthcare, but he says the third revolution has already started in industry. It's driven by three forces: citizens, knowledge, and this. Thank you very much.